Okay, thank you once again, and good morning to all the participants. So I'll just start my talk on the neuroimaging findings in neonatal encephalopathy. So this is a very vast topic, but I shall try to condense it and bring out some of the salient points in this next half an hour. Yeah, so this is just a brief overview of what I'm going to cover. What is the role of ultrasound and CT, basic MR protocol that needs to be followed, and then the imaging findings in various causes of encephalopathy in the newborn. So what about cranial ultrasound? Ultrasound has a limited role, but definitely in the neonatal ICU, in a preterm or in any an infant who is sick, it is very useful, especially since it involves minimal or no disturbance to the neonate, and it can be done in the bedside. And it's also easily available. So this is the primary imaging modality to detect germinal matrix hemorrhage, hydrocephalus, white matter changes in preterm neonates, especially the cystic variety. Now CT, as Dr. Manisha had mentioned earlier, it has a number of advantages, especially that it's easily available, it's very fast and versatile, can be useful in hemorrhage, birth trauma, and stroke, and in detecting various complications of meningitis like empyema and venous thrombosis. But in the neonate, especially in the setting of neonatal encephalopathy, it has a very limited role. And the main disadvantages are the radiation involved and that the resolution is not as good as MRI for assessing malformations, inborn errors of metabolism, and white matter changes. So as we all know, MRI is probably the most sensitive imaging modality for evaluating the developing brain. And this provides detailed information without exposing the neonate to ionizing radiation. The main role is to identify the cause and the nature of insult, and also to predict outcome and the extent, that is the extent and pattern of injury based on the extent and pattern. What is the MR protocol that needs to be followed? So this is the basic protocol that is followed, that is diffusion-weighted images, T1-weighted imaging, T2-weighted imaging, SWI, and MRS. So I'll just go over these different imaging sequences. I know we've had a detailed description and on these sequences already, but this is just in this context. So diffusion-weighted imaging is the most informative, especially in neonatal encephalopathy, and it can be performed first. This is a normal scan in a term neonate, and this is what the diffusion-weighted image would look like, and this is the ADC map. This is in a neonate with hypoxic ischemic encephalopathy, showing areas of diffusion restriction in the basal ganglia and in the parieto-occipital cortex. Now, axial T1-weighted image, basically it's very useful to detect myelination in the term neonate, useful for picking up ischemic foci, subacute hemorrhage in the putamen, thalamus, and the plic. So this is a term neonate. Again, we can see that the posterior limb of internal capsule or the plic is myelinated, and this is typically seen as a hyperintense band. Axial T2-weighted sequences, again, they provide a very good contrast between gray and white matter, and it's useful for accurate characterization of the cortex and deep gray matter in the premature brain. So identification of white matter signal abnormalities, that is the diffuse excessive high signal intensity, which can be seen in preterm infants, can be picked up on T2-weighted sequences. Now, SWI or susceptibility weighted sequences are also very useful, especially since it can identify hemorrhage and this distinguishing it from ischemic foci, which can be seen on T1-weighted images. Also, it is useful to detect cerebral venous sinus thrombosis, cortical venous thrombosis, and medullary vein thrombosis. Now, MRS has a role in neonatal encephalopathy, and typically an intermediate echo time is used where we can see an inverted lactate peak at 1.3 ppm. A short T, that is 30 to 35 milliseconds, can be included if a metabolic disorder is suspected, where we can see a glycine peak at 3.56 ppm. Now, these are the basic sequences that need to be acquired, and ideally, these need to be reviewed by a radiologist as soon as the scan is done, and then additional sequences can be planned based on the clinical indication. So if there is a suspicion of a cerebral venous thrombosis, then we can go ahead to proceed with an MRB to look for the extent of thrombosis. And we also need to remember that in a neonate, due to the higher water content, lower protein and lipid content, the standard sequences that we use in adults cannot be used, and these need to be adapted to be used in neonates. Now, coming to the causes of neonatal encephalopathy, now the most common cause, of course, is hypoxic ischemic injury, and then the others are the metabolic disorders, congenital and neonatal infections. It can be vascular causes, major congenital malformations, and birth trauma. So now we just go over some of these causes, starting with the first one, that is hypoxic ischemic encephalopathy, which is the commonest cause for neonatal encephalopathy. As we know, in full-term neonates, this accounts for about 15 to 20% neonatal mortality. And in preterm neonates, there's a higher mortality and morbidity. So the common pathophysiological process that is involved is that there is a decreased cerebral blood flow causing ischemia and a decreased blood oxygenation causing hypoxemia. So this, in addition to inflammation, can cause a severe energy depletion, resulting in cell death, or when there is a lesser degree of energy depletion, it results in a programmed cell death or apoptosis. Now, the pattern of injury depends on three main factors. That is, the brain maturity at the time of insult, the severity of hypoperfusion, and the duration of hypoperfusion. So, based on the severity of perfusion, when there is a severe hypoperfusion, the vulnerable areas, that is, the areas of increased metabolic activity and the areas of greater myelination, are the ones that are affected. However, if there is only a mild to moderate hypoperfusion, there's a redistribution of blood to the metabolically active areas, and injury occurs to the watershed areas. Now, looking at preterm neonates, what is the pattern of injury that we see? If there is mild to moderate hypoperfusion, what we can see is a germinal matrix hemorrhage, periventricular leukomalacia, or a combination of both. If it is a severe hypoperfusion, the structures that are involved are basically the structures that are already metabolically active and myelinated. That is the thalamus, the anterior part of vermis, dorsal brainstem. So other sites which can also be affected are the basal ganglia, the hippocampi, cerebellum, and corticospinal tracts. In a full-term neonate, if there's a mild to moderate hypoperfusion, the sites that are initially involved, that can be involved, are the subcortical white matter or the parasagittal cortex. In a severe hypoperfusion, sites that are involved include the lateral aspects of the thalami, the globus pallidus, the posterior aspect of putamen, hippocampus, brainstem, and the sensory motor cortex. So looking at each of these different findings or scenarios, so in a patient with a germinal matrix hemorrhage, this occurs usually in the first 24 hours of life. And cranial ultrasound is again very useful to detect germinal matrix hemorrhages. And these can be performed in the ICU without having to shift the neonate for another scan. However, MRI is found to have a higher sensitivity than ultrasound for small germinal matrix hemorrhages. So this is an MRI T2-weighted scan in a neonate performed at term equivalent gestational age. So we can see a small cystic area at the caudothalamic groove region. And on SWI, we see that there is blooming here, indicating that this was a small hemorrhage. And again, we also see other areas of hemorrhage along the ventricular margins and minimal blooming within the occipital horns of the lateral ventricles. So MRI is also very useful to predict periventricular venous infarction in grade 4 GMH, and post-hemorrhagic ventricular dilatation can also be seen both on ultrasound and MRI. And this is an indicator of poor neurodevelopmental outcome. So intraventricular hemorrhage can subsequently also cause iron-induced white matter injury. Cerebellar hemorrhages basically can occur in up to 25% of preterm very low birth weight infants. And this is assumed to arise from the germinal matrix zones in the external granule cell layer and the subependymal layer of the roof of the fourth ventricle. So these are T2-weighted axial and coronal images showing tiny foci of hemorrhage in the cerebellar hemisphere on the left side, with corresponding gradient or SWI images showing blooming in that region. Now, periventricular leukomalacia is also known as a white matter injury of prematurity. So there's a cystic variant which can appear as areas of cystic change due to focal necrosis in the deep white matter, or there can be a non-cystic variety where there is diffuse injury to the pre-myelinating oligodendrocytes. So the common sites of involvement are the peritrigonal regions and adjacent the foramen of Monro. And these correspond to the watershed zones in the periventricular white matter in premature brain. So this is a T2-weighted image, sorry, a T1-weighted image showing multiple foci of hyperintensity in the deep white matter. Okay, so these correspond to ischemic foci. So basically we need to remember that on a T1-weighted image, hyperintensity in the periventricular matter could indicate ischemic foci, and if there is corresponding blooming on SWI, then it would be a hemorrhage. Now, we talked about acute changes in periventricular leukomalacia. So very often we may see a sequel of that is end-stage PVL, where there is extensive white matter volume loss. And on a FLAIR image, we can see hyperintensity in the periventricular white matter. And if you see, the ventricular margins are very wavy. And on this axial weighted scan, we can see that there is extensive loss of white matter. And the ventricular gray matter has almost reached to the ventricular margin. And these ventricles have wavy margins. This was a 6-year-old girl with cerebral palsy, and MR shows again sequel of HIE or periventricular leukomalacia in a preterm infant. So there is complete loss of periventricular white matter, and the gray matter is almost touching the ventricular margins. So the ventricles have wavy margins. And on a sagittal image, we can see that the corpus callosum is completely thinned out. And if you notice over here, these are the FLAIR images. So although there is white matter loss, there is actually no hyperintensity. So this can occur when the baby is very preterm, that is born even before 28 weeks, when the brain actually cannot elicit a gliotic response to the periventricular leukomalacia. Again, these two images, this first one is abnormal and the second one is normal. Both are T2-weighted scans. So over here, we can see that there is a diffuse excessive high signal intensity on T2-weighted images. This can occur in about 65 to 75% of preterm infants at term equivalent gestational age. And this is known to correlate with reduced developmental quotient at 18 months of age. Scattered punctate white matter abnormalities have also been described. These are common findings in preterm brains, but this is not known to be predictive of an adverse developmental outcome. Now, what are the findings in full-term neonates? We'd already gone through that in the algorithm. But so just to recap, again, mild to moderate hypoxic ischemic injury usually affects the watershed areas, that is the parasagittal cortex and the subcortical white matter, and usually spares the brainstem, cerebellum, and deep gray matter structures. This is a 5-day-old neonate with a history of perinatal asphyxia, showing areas of diffusion restriction in the parasagittal cortex. Okay, this is a diffusion-weighted image, and these are the ADC maps. With severe hypoxic ischemic encephalopathy in a full-term neonate, like we mentioned earlier, the plic on a T1-weighted image normally should appear bright, as a bright band. Now, in severe or profound hypoxic ischemic encephalopathy, this signal, it can be lost. Okay, and when this is lost, this is supposed to be an indicative of profound hypoxic ischemic injury, and it is an excellent predictor of abnormal outcome. So this image is actually, this is normal and this is abnormal. In the abnormal image, you can see extensive hyperintensity in the basal ganglia and in the ventrolateral thalami, with loss of the T1 hyperintense signal in the plic. So the other sites, like I mentioned, in a full-term neonate, which can be affected, are the ventrolateral thalami, the posterior putamen, the perirolandic regions, and the corticospinal tracts. So MR imaging, as you have seen, is the most accurate imaging modality for evaluating hypoxic ischemic brain. So, however, the imaging findings that we see vary with the time of imaging. So at 1 to 2 days on conventional imaging, we may show some subtle changes on T1 and T2, but these signal changes are more marked on T1 images at 3 days, around 3 days, and only after about 6 to 10 days, marked signal changes are seen on T2-weighted images. Now, flare on in a neonate does not actually add anything additionally, but if like there are cystic areas, it may show some suppression. Now, the diffusion-weighted imaging again has, as I mentioned earlier, has the highest sensitivity for early detection of injury. So if it is performed in the first 24 hours, it can underestimate the extent of injury. By 3 to 5 days, that's when maximum abnormalities are seen. And more than 5 days, if imaging is performed, diffusion-weighted signal changes can actually normalize. So the absence of abnormalities at 24 hours in the setting of severe hypoxic ischemic injury, if it is clinically suspected, would require follow-up imaging after about 2 to 4 days. Now, these are some ADC values which have been found to be associated with true ischemic lesions, that is white matter in the white matter and in the thalami. These are just a few examples of infants with hypoxic ischemic injury. So this was a 9-day-old infant with meconium aspiration, profound hypoxia. So this first image is a T1-weighted scan showing hyperintensity in the ventrolateral thalami and in the basal ganglia. So the plic is not seen. T2-weighted scans again showing hyperintensity in these areas with diffusion restriction in the posterior putamen and in the perirolandic cortex. A 14-day-old neonate, maternal preeclampsia, and what we can see is that there is extensive white matter changes. This is a T2-weighted scan where we see diffuse hyperintensity in the white matter, gyral swelling and effacement of the sulcal spaces, and also areas of hemorrhage along the ventricular margin. On a T1-weighted scan, again, the white matter appears markedly hypointense and the cortex appears bright. Diffusion scans, again, showing extensive diffusion weighted signal changes. This was an extensive sort of a global insult to the brain. And MRS, I'll talk a little bit about that later, but shows a reduction in Na with a small inverted lactate peak at 1.3 ppm. This is another neonate with profound hypoxic ischemic injury. This was done in the neonatal period. On T1, again, hyperintensity in the basal ganglia with loss of the hyperintense signal on plic. Diffusion-weighted scans shows extensive diffusion restriction in the supratemporal cortex. And a follow-up MRI at 4 months shows extensive changes in temporal parenchyma. So with this, we can see that definitely the overall outcome would be poor. Here is HIEs equally, like I mentioned, the changes on HIEs and the term involved ventrolateral putamen, ventrolateral thalami, the corticospinal tracts, and the perirolandic cortex. So these areas at 3 years of age are showing evidence of gliosis or uligaria with volume loss. And on a T1 sagittal image, we can see that there is marked callosal thinning. A 7-day-old neonate with hypoxic injury underwent therapeutic hypothermia and follow-up imaging. There were signal changes seen in the basal ganglia, but once the diffusion scans, these changes are not very evident. A tiny focus of diffusion restriction in the peritrigonal region. So coming to the effects of hypothermia on routine image on MRI. So as we know, if therapeutic hypothermia causes a significant reduction in neurodevelopmental disability in early and 8-month follow-up. It reduces brainstem, thalamic, and corticospinal tract injury. However, it does not significantly decrease extent of watershed injury and when there is severe injury or total brain injury. So what are the effects of therapeutic hypothermia on an MR scan? So what has been described is that without therapeutic hypothermia, the ADC values can normalize after about 6 to 7 days. However, with therapeutic hypothermia, ADC values normalize only after about 11 to 12 days. The other points are that in the first 1 to 2 days after therapeutic hypothermia, ADC values can be about 10% higher than normal. They've also found that there is a 10% increased incidence of intraventricular hemorrhage with therapeutic hypothermia. So this is a study again looking at, this was in 2016, but it found that definitely MRS had a role, and there are some pitfalls when you interpret MRS in the neonate, because normally we see a higher NA peak in an adult, but in neonates it's known that NA will be lower. So in hypoxic ischemic encephalopathy, this NA level can be even lower and a lactate peak can be seen. But they have found that definitely there is a significant difference in these peaks between infants with hypoxic ischemic encephalopathy when compared to normal neonates. So they've said that MR spectroscopy can be used as a complementary tool for the diagnosis of HIE. This is another paper from Journal of Pediatrics in 2021, looking at the effects of therapeutic hypothermia and how it can predict 30-month outcomes after neonatal encephalopathy. So they have said that with the normal MRI following therapeutic hypothermia, it sort of remains reassuring that there can be a fairly better outcome or a normal outcome at 30 months. Although I feel that definitely we need to go by the clinical presentation, and even though MR findings does not show severe changes, we do need to be cautious when predicting outcomes. So that is about hypoxic ischemic encephalopathy. Now moving on to the metabolic disorders that can cause neonatal encephalopathy. So as you can see here, there is a long list of causes and we won't be able to cover everything, but we need to remember that metabolic disorders need to be suspected when encephalopathy occurs a few days after birth and for no obvious reason. If there is no definite history of clinical features to suggest a hypoxic ischemic injury, and we do need to consider the possibility of an underlying metabolic disorder. Other history, like past history of any sibling death in the neonatal period or early neonatal deaths or parental consanguinity, may also alert us to the possibility of an underlying metabolic disorder. So these are just some of the salient imaging findings that we can see. So with urea cycle disorders, extensive cortical and subcortical involvement can be seen with some thalamic sparing. Organic acidureas and aminoacidureas, aminoacidopathies, basically glutaric aciduria. The typical finding is extensive frontotemporal atrophy with widened sylvian fissures, and they can also have basal ganglia abnormalities. In maple syrup urine disease, there can be extensive cytotoxic edema of the myelinated white matter. In methylmalonic and propionic acidemia, they can have extensive cerebral white matter abnormalities, also involving the basal ganglia. Typically, the globus pallidus is said to be more involved in the methylmalonic acidemia, and the caudate and putamen can be involved in propionic acidemia. In non-ketotic hyperglyceminemia, we can see restricted diffusion involving the plic, the anterior brainstem, the posterior tegmental tracts, and the cerebellum. MRS typically shows a glycine peak at 3.56 ppm. Now, isolated sulfite oxidase and molybdenum cofactor deficiency, they can have extensive changes involved with diffusion restriction, which can mimic HIE. So some differentiating features are that with these conditions, caudate nuclei can also be involved, which is not typically seen in HIE. And the other factor is that usually, even with profound HIE, infants seem to stabilize after 1 to 2 weeks, but this does not happen with these conditions. So this, going over a few cases, 12-day-old neonate with parental consanguinity, history of neonatal death, presenting with metabolic acidosis, hypoglycemia, and encephalopathy from day 9. On the T2-weighted scan, we can see extensive white matter changes in the cerebellum, the dorsal brainstem, and the plic also appears expanded and hyperintense. On diffusion-weighted scans, we can see hyperintensity or areas of diffusion restriction in all these involved areas. And this was a case of maple syrup urine disease. So, next case, baby girl with a history of neonatal death in a sibling. Day 2 scan, encephalopathy, showing again areas of diffusion restriction in the plic, in the cerebellum, and in the brainstem. On MRS, there was a glycine peak at 3.56 ppm. That was a case of non-ketotic hyperglycemia. This was again a 9-day-old infant with seizures from day 4 of life, showing extensive diffusion restriction in the white matter. So this was thought to be a metabolic disorder, and further workup was recommended. Neonate again with features of encephalopathy on day 3 of life. So over here, the T2 scan shows extensive white matter changes, hyperintensity, and on the diffusion scans, there's extensive diffusion restriction in the cortical and subcortical regions, also involving the basal ganglia, nominally the caudate nuclei. And on MRS, there was a large inverted lactate peak at 1.3 ppm. So this was a case of sulfite oxidase deficiency, and can have similar imaging findings to a molybdenum cofactor deficiency. Pyruvate dehydrogenase complex deficiency is also one of the causes of catastrophic or devastating neonatal encephalopathies, which can present quite early. Typical finding is the presence of a hypoplasia or an agenesis of the corpus callosum, along with lactic acidosis. So the other findings are ventriculomegaly. They can have cortical malformations, can have extensive white matter changes with cysts in the white matter due to necrosis. And if findings are supposed to be more extensive in females. Now, in Menkes disease, basal ganglia signal abnormalities can be seen with areas of T2 or flare hyperintensity. There's extensive white matter changes and marked volume loss. Elongated tortuous cerebral vessels can be seen at the basal cisterns, and they can also develop bilateral large subdural hematomas due to the volume loss. Glutaric aciduria type 1 may just present with macrocephaly, but can also have bilateral large subdural hematomas. Okay, so typically they have widened sylvian fissures. They can also be basal ganglia signal abnormalities in this condition. What about the peroxisomal biogenesis disorders like the Zellweger syndrome? Again, can present in the neonatal period. They can have profound hypomyelination, diffuse cortical migration and sulcation abnormalities, germanolytic cysts near the foramen Monroe, and other findings include intra-articular calcification. So typically, the sulcation abnormality is there are multiple small gyri. It's not typically polymicrogyria. Now, neonatal hypoglycemia, we do see the sequel of this in older infants quite often. But we need to remember that transient hypoglycemia usually does not cause significant changes in the brain. Injury is usually seen when there is a prolonged or severe hypoglycemia, or if there's a combination of hypoglycemia with a mild hypoxia. Then we do see significant changes, and typically changes are seen in the parieto-occipital region and splenium of corpus callosum. Okay, and it's also important to remember that infants with other severe metabolic disorders and having a severe metabolic decompensation can have changes related to hypoglycemia as well. So some of the common congenital and neonatal CNS infections that we do see are the human paraechovirus infection. HSV, unlike in adults, in neonates, they can have a more diffuse involvement, can be multifocal changes which are limited to the temporal lobes, the cerebellum, brainstem, and they can be deep gray matter involvement. Okay, so usually the neurological outcome is quite poor in infants who develop HSV. This is the typical appearance of a paraechovirus infection. On T2, there's extensive hyperintensity, some foci of T2 hypointensity. On diffusion images, we see these linear or foci of diffusion restriction in the subcortical and deep white matter with involvement of the corpus callosum. And these areas appear dark on ADC maps, indicating restricted diffusion. Some other viruses like the enteroviruses, dengue can also have a similar appearance. This was a 19-day-old neonate with sepsis. And what we see here is extensive cystic areas in the periventricular white matter, which are lined by hemosiderin, as seen on the SWI image. This was a case of Citrobacter meningitis. So vascular causes, both arterial and venous infarcts or venous causes are known to cause an encephalopathy in the neonate. This was a term neonate with symptomatic with hypoglycemia and seizures, who was stabilized and discharged. And just before discharge, this MRI was taken, and it showed a large infarct in the right MCA territory. So this neonate otherwise was doing well. However, came back 1.5 years later with history of seizures, and you can see an area of gliosis which corresponded to the previous infarct. This was a 4-day-old neonate who had mother had undergone a section, cried at birth but developed left focal seizures at 2 hours of birth. It showed multiple areas of infarction in the supraconchodial parent lobe. So this is a 9-day-old neonate with left focal motor seizures. So T2 scan and SWI and T1. On the T2 scan, we can see that there's a loss of normal flow void in the internal cerebral veins. There's intraventricular hemorrhage. There's hemorrhage along the ventricular margins. And on the SWI, you can see that the internal cerebral veins appear more prominent. There is extensive intraventricular hemorrhage. And on T1, again, we see T1 hyperintensity in the internal cerebral veins and the veil of Galen. This was a case of venous sinus thrombosis. A preterm infant with premature rupture of membranes, depressed at birth, and MRI done showed subdural, subarachnoid, and intraparenchymal hemorrhage. So there was a component of sepsis as well, and this definitely would explain the neonatal encephalopathy in this infant. Now, some congenital malformations, especially the major ones, can present with neonatal encephalopathy, and we need to be aware of that. Again, MR has an important role in actually detecting and confirming these findings, which may be just a suspicion on on an ultrasound, screening ultrasound. So this was a term neonate with seizures on day 4, and MR was performed, which showed actually corpus callosal agenesis with abnormal sulcation and dysmorphic basal ganglia. This was another neonate with encephalopathy showing features of a Joubert syndrome. This is the typical molar tooth sign. And there were also other features of probably a hypoxic ischemic injury with areas of hemorrhage in the parenchyma. So now just summarizing some of these causes that we saw. So on day 1, the child presents or neonate presents with an encephalopathy. The most important or the commonest cause that we would have to think of would be a hypoxic ischemic encephalopathy. The other causes would include hemorrhages and other severe metabolic disturbances like a PDH complex deficiency. Major congenital malformations can also present on day 1. On day 2 to 3, we need to consider various arterial vascular causes like arterial infarcts, venous thrombosis, hypoglycemia, metabolic defects in the energy production and the urea cycle disorders, infection. Day 3 to 5, other IAMs, viral encephalitis, congenital malformations. So this is just a broad guideline. It may not always be true, but these are some things that we need to remember. So in conclusion, we have seen that MRI remains a powerful diagnostic tool for the evaluation of the encephalopathic neonate. Hypoxic ischemic encephalopathy, we need to remember the characteristic imaging patterns which are based on the degree of brain maturity and also on the duration and severity of injury. So MRI has a great prognostic value while carefully reviewing clinical history and interpreting scans. So if there are any unusual imaging findings, go back to the clinical history, we need to consider other differentials. Accurate diagnosis is very important to allow to provide the most appropriate therapeutic options and adequate counseling. So I would like to thank the organizers for this opportunity, the departments of pediatric neurology, radiodiagnosis, and neonatology in CMC. Thank you.